Thanks, Shubhra. Again, a pleasure to be here, and thanks again for the organizers and Dr. Gangopadhyay for inviting me here. What I'll do is give you a very quick view of wounds, um, why you want to measure wounds. You know, most of us don't get into this business till it's too late, right? And talk a little bit about what's been done, what could be done, and where we are. Okay. Um, and try and highlight some very fundamental challenges for you, and that if somebody can solve, we are game changers. So you can, and I'll go very fast because I know we're a little late, but you can have wounds of two kinds. One is like an open wound, which is a cut, or a conclusion or a hematoma, which is like at the bottom you see those sprains. This talk focuses on open wounds, right? Now, if you look at wounds, it's a big business economically. Surgical wounds account for 62% of the wounds that are on somebody. But the biggest cost wounds are in the area of diabetes, venous ulcers. These are chronic wounds, and they are very expensive for society because the end result might be amputation, basically, right? They're generally, the wounds happen because there's not enough blood flow. Wow. So I'll just continue talking so that we don't get too far behind, right? So what generally happens is your wounds, typically chronic wounds, it's about blood flow. And if your wounds are not bathed in blood, you're not having enough exchange, not enough oxygen, the wound festers. And with diabetic patients, wound healing is a very big problem. Okay, and for venous people also, wound healing is a very big problem. So how do you measure a wound? So typically what happens generally in wounds is it's not the wound, but wound is a problem. You can treat it. The biggest complications arise because of lack of patients following up a regimen for wound healing and wound care, right? You have to go to a wound clinic, get yourself bandaged maybe every 2 days, every 3 days, every 5 days, and logistically very inconvenient. So people occasionally skip on it, right? So there are some very basic techniques out there that are in practice today. One of them is just you kind of size the wound. Okay, you put a scale and a grade and you kind of map the wound. Okay, very common way of measuring a wound. And then you're trying to do that digitally now. But digitally, the problem is on the edge of the wound is necrotic tissue. And it's very hard to gauge the size and impact of those, right? And most visual inspections that you do, you can only do it at change of dressing time. And some of these wounds and like bed sores and all progress very fast. So when I've heard at Duke, that people would come this week for a wound clinic, and they come 10 days later and they have to amputate because the wound was festering. So things go down very fast in wound care. So the question was, can you monitor a wound, right? And so work has started on it. But if you're looking at how a wound progresses, typically is you have 4 stages. And the whole idea is how quickly the inflammation goes down and the cell proliferation starts. So in chronic wounds, that cycle gets completely disrupted, okay? So if you're looking at a normal skin, we are acidic, okay? Healthy wounds tend to be acidic, chronic wounds tend to be alkaline. You suddenly realize, well, I can monitor pH and kind of get a track on the wound. So people have done that. There's a bunch of things that have happened recently that some of Sameer's work on the top. So you're looking at primarily so far what has been looked at is pressure, temperature, pH, and hydration, right? In the sense if the wound is oozing or drying up. And then, like I said, these are the generations that have come on Band-Aid. Okay, but they're all still pH, temperature, and pressure. What else can you measure? This one is Sameer's work, recent work, where he's doing temperature and drug delivery. The challenge with this work occasionally can be that wounds tend to form a scab. So once they kind of cross-link and make a scab, it's very hard to get anything through it. So it can work, it cannot work, because if it doesn't work right the first time, then you have to go back and change it and start again, right? The question is, all these techniques, not one of them can't singularly provide to you with a quantitative measure. If you're looking at a quantitative measure of wound healing, you should look at how cells break down, right? This is second in biology for all of you engineers, right? But what happens is the DNA breaks down. When cell dies, there's a lot of gunk. The DNAs break down. The green pathway, the A and the G, they break down. There are a gazillion of byproducts, and you can choose and decide which one do you want to go after. Okay, there's uric acid that I'm going to talk about today, and then xanthine. Uric acid is a little more stable. So the first question was, understand the pathway, understand the molecules, figure out which one you can go after. And for us, they were very simple boundary conditions. It had to be continuous. It shouldn't require any other fluid that you require in microfluidics to clean, purge, this, that, or the other. It needs to last for 7 days. Okay. Lab, we work at 24 degrees, typically 23, 24 degrees. On body, you are at about 39.6, could be 40, right? And if you're sitting on a hot car, it could be 45. So it needs to be stable up to 50 degrees C. So how do you stabilize something to 50 degrees C? Two ways to do it. You invent new materials, which requires you to be a biologist or biochemist, which I'm not. So as an engineer, what's the best thing you do? You look at the standard materials and figure out how to stabilize them. And we went with the second approach, right? And figure out how to stabilize them. So we looked at uric acid, and on the right, what you see is a standard curve for wound healing for chronic wounds and healthy wounds. That the uric acid levels go up and come down, and a chronic wound, they'll kind of stay up. Okay? Again, it's a non-specific marker. You can have it in gout. You get uric acid in your sweat. Cells die all the time in the body. You have to make a differential measurement, right? So the first thing was, well, there's a good hypothesis, does it even work? If it's going to work, how it's going to work? So this was our concept, which is basically you start with a smart Band-Aid. You measure uric acid, pH, temperature, moisture. And like I said, pH, temperature, moisture has been measured before. So we didn't spend a lot of time on it. We focus on uric acid. And you get it to a handheld system, and then you take it to the cloud. So that was the basic framework, right? So we started. We took uricase, which is an enzyme that breaks down uric acid to alkaline, and we measured those, and we put them down on a substrate, and we realized electron transfer is a problem. So we used a mediator, right, FCA, and then we said, okay, there's an enzyme, and then there's a mediator. Why don't we just go double enzyme pathway? So we are basically using uricase and HRP. That's some of our most recent work. So we were, on one side, we are looking at what mechanisms to work with, and how do you encapsulate and trap these enzymes to keep them stable at 40 degrees, right? So this is how we are building it right now. You start with a bare electrode, you put nanoparticles in there, functionalize them, a job enzyme, and the physics-jobbed ones don't really work very well because the enzyme fades. So we have entrapped enzyme in PVA, which is like surgical grade glue. So the other thing we've looked at is biocompatibility of the materials that are going in at the back end, right? And then you've been looking at the signals that you get from everything. The next thing that happened is, this was, okay, this is how you're going to make it on a polymer sheet. Now I'm trying to make it on a gauze, on a fabric, right? And I can't just decide that I'm going to use a different kind of fabric, because you can't change the protocol for a patient and a doctor. So the challenge was, how do I get good conductivity on these fabrics? And these are very well designed. These are 7-layer, 5-layer designs designed to wick fluids up. So you can't really do much to it. So what we did is we started printing nanoparticles, but we use plasma to anneal and get a good conductivity. Because if you don't have good conductivity on your electrodes, your signal gets messed up, right? So we've been using plasma to get good conductivity, and it's been working very well, right? So this is some of the early work. We have those electrodes on a flexible sensor with the twin enzyme work, which is the most recent work that we have done right now. And we started with one sensor, right? And now the question is, you don't know where you are on the wound when you're not, as an engineer, I'm not the one who's dressing this Band-Aid. So our next concept is trying to put multiple sensors in what might be a wound area, right? And then we were saying, okay, does it really work? So that's me with the sensor on me, and we just spiked myself with uric acid just to see whether it'll respond, right? Skin will respond, and it responds. Now the challenge that we face right now is if the wires move, and wires will move, they dominate the noise. So the signal, the connectivity, the interconnects are the biggest problem right now in a construct like this. Because you have a flexible substrate that's bulging, so electrode distances will change, capacitive coupling changes. So you're suddenly looking at how you're going to stabilize the electronics that goes behind it, or the electrical signal. And so you're kind of messing around with it. But on the bottom, what you're looking at is sensors that are placed on patients. You're looking at the uric acid levels from the wound, from areas near the wound, and typical measurement from a healthier part. So if you have a wound on your leg here, so on the wound, and I'll show you some dressings in a minute, and then around the wound, and then maybe the other side of your leg, and comparing the uric acid levels there. So you can see there's decent variation, and at first pass, you can see that wounds tend to have a high uric acid level. So now, why is there such a lot of variation on a healthy adult? Is a function of how the wound was applied, how the sensor was applied, how long was it on the body, how well it was packed. So there are a lot of variables there that's still we are still working on standardizing. This was the first set of our clinical studies, right? But like I said, we're also looking at all these materials that you're going to put in. They're going to be in an open wound. You want to make sure that nothing is toxic. So we have a whole bunch of biocompatibility studies going on with materials. And so that has been cleared by IRB. So this sensor can now actually go in. And so we have a new form that, patient consent form that we just filed, which will basically allow us to put the sensor on the patient, right? Like I had told you earlier, the entire process, we are basically getting rid of liquid electrolytes. So if you're going to get rid of liquid electrolytes and you're struggling with conductivity of nanoparticles, the next thing we're looking at is conductive gels as conductors, ionic gels conductors. So it's coming down to, you have a problem and you're using materials and material science to solve the problem, just find out which is the most efficient way to do it. But this is how we've done the work so far. So what you see on the left is wound from a dressing, used dressing from a patient. We get those from the wound clinic at University of Miami. And then we run the samples. The sweat has been done on healthy patients, because most of these patients who have these lower limb wounds are typically on wheelchairs, half of them. So they're not exercising. So we did sweat on healthy volunteers who are going to the gym. And then we realized that, there's a funny interference that happened. If you are one of those guys who really exercises a lot, and you get into a close to ketoacidosis, you start getting fat in your sweat. So we're just learning a lot about what goes on in the body as we are kind of messing up with it and collecting samples. And then you have to figure out, okay, how do you take care of fat? Because you're not going to spin it out. It's a wearable patch, right? So we're kind of looking at that right now. So our current generation of sensors that's going in bulk is screen printed. And the next generation is going to be plasma printed. But plasma printing is a really slow process, so we're still, for the current clinical trials, are stuck with screen printed sensors. Right? So remember I said flexible wounds have a challenge for us? Here's a comparative response of LTCC-based carbon sensor and a flexible sensor. So bioenrichment plots, for those of you who don't know it, is basically comparing two different methods for measuring the same signal, right? And how tight it is. So you don't want these trend lines that you're seeing there, right? So there's the average of the A versus B, right? The comparative response of flex versus hard. And what's the difference between the currents? You would effectively want it to be a flat line, ideally. So like I had said, that this is one of the challenges you're working towards. So that still remains a challenge that we're trying to solve, right? So I'll conclude here with the fact that we've made some uric acid sensors to try and complement all the work that's been done before. We've done uric acid sensing with different kinds of sensors and modules, and have tried to come up with new materials to try and incorporate on standard medical substrates, right? And we are into human studies. I'll stop here and take questions.